Hello, and welcome to Phoenix House Foundation's first training on the dsm5. This introductory training was designed and developed by Dr. Danielle Moreggi and provided through the Phoenix House National Clinical Training Department. At the conclusion of viewing this recorded webinar, you must complete the 10-question quiz on the content within this webinar. Towards the end of this recording, there is a brief Q&A where Dr. Moreggi answers questions from Phoenix House staff that are the most relevant for the addiction professional. And now, here's Dr. Moreggi.
Okay, hello everyone. It is my understanding that I'm speaking to people across 12 different states today. Today I will be going through the changes that every co-occurring professional should know in the DSM-5. In the DSM-5 there's an enormous amount of changes, and I chose the information today to go through based on my experience with co-occurring professionals and clinicians in terms of what you see the most. Obviously, we're going to go through the addictive disorders changes, which are pretty cumbersome, but also in this presentation, I will be highlighting the overall structural changes and highlighting some of the different diagnoses that have changed, for instance, PTSD, trauma, bipolar-related disorders, and so forth. So just to begin today, I have a slide here that's just reminding everybody, wondering which DSM-5, or I should say which DSM manual you are the most familiar with. I have been doing DSM trainings for, I would say, the last 15 years, and I am the most familiar with the DSM-4. And the new DSM-5 has pretty much a very, very different feel to it, for lack of a better word. It's actually a manual that you can read left to right. Versus some of the other manuals that were published prior to this. What I have here on the slide is reminding everybody that the DSM-4 was published way back in 1994. The DSM-TR, published in 2000, really didn't have any categorical changes to it. There was only textual and wording changes. So in essence, one of the reasons why the DSM-5 has so many changes is because it represents almost 20 years of the American Psychiatric Association really updating what we consider abnormal and disordered behavior. So over 20 years, there's been an enormous amount of changes in our culture, how we perceive diagnosis, and then therefore how treatment flows from that. So there's a big reason why there's so many changes. One of the things I'd like to do today is just, one of my goals for the day is to demystify some of these changes to help people not be so overwhelmed, kind of break things down into categories, and then maybe make your own assessment as to whether or not you feel that you need further training or you're comfortable with documentation and so on. So in the DSM, one of the things that is the same for each manual that is also included in the 5 is that the American Psychiatric Association has published this manual and does not provide treatment guidelines for diagnosis. That is still on the responsibility of the clinician. So as we go through things today, a lot of the information is really geared for the clinician that is doing the initial assessment, figuring out what the diagnosis is, and then having the diagnosis really be responsible for guiding treatment. So the other part is once you have the diagnosis correct, then treatment goals and certainly even outcome measurements are possible and more valid. The use of the DSM-5 is to assess for the presence of a mental disorder, not by someone who's clinical or not medical, is very much insufficient in this manual in particular. The DSM very much in this manual, more so than other manuals in the past, assumes that the diagnosis is being made by trained diagnosticians. In other words, having already been familiar with previous versions of the manual. So, determining the presence of a diagnosis. When we meet a patient for the first time, clinicians are ethically responsible to form an accurate diagnosis, and you'll hear me mention several times that diagnosis guides treatment. That clinical interviewing is really one of the most important assets a clinician can have. The more structured around diagnostic elements, the easier it is to make a diagnosis. And what I really mean by that is during a clinical interview, asking specific questions that are related to specific symptoms. So For example, if you're assessing depression, you want to ask questions like, how is your sleep? How is your appetite? And so on and so forth. Interview questions also really for the purpose of determining differential diagnosis. As you go through clinical interviewing, as most of you are aware, getting yes or no or maybe or I don't know answers from a patient can often be a little bit challenging, particularly for the co-occurring population. And specifically, what the DSM is designed to do is not to just help with making a diagnosis, but also determining whether a diagnosis is or isn't there, and then is the diagnosis valid or could it be something else? So before I go any further, this is just a personal assessment that I ask of everyone to just take a moment and think about. Ask yourself these three questions. In your professional education and training, how many hours have you studied the DSM-4? The DSM-5 is very much based on comparative analysis to the DSM-4. So just thinking about how many hours have you actually sat down with the DSM-4, made or attended a previous training, taken abnormal psychology as a graduate student, things like that. How comfortable do you feel in your ability currently to identify and diagnose co-occurring disorders? In other words, identifying, like I said previously, the diagnosis itself, and then deferring it to how it relates specifically, relates or not specifically to a substance abuse disorder as well. And then lastly, how comfortable are you with your ability to document the reasoning for a diagnosis? And that is something that I know most clinicians have a lot of questions about with the DSM-5 language turning over to the ICD-10, which is coming up next year, and I will talk about later in this presentation. I know many of you will have questions about how does this affect billing, documentation, paperwork, reimbursement issues, and so on and so forth. So what I mean here by your ability to document the reasoning, I mean document the justification for the disorder itself. So to start today, we're going to go through some of the overall structural changes of the manual. It's actually broken down into three sections. And in section 1, unlike the previous versions of the manual, it's pretty readable, in my opinion. It goes over the overall changes to the manual, how the manual is set up, how it is intended to be used. And section 1 is briefer than the other sections. All the disorders are listed in section 2. And in section 3, there are assessment measures, conditions for further studies, some appendages, charts, different measurements that are helpful with diagnosing. One of the things that has been asked prior is, are there still decision trees in the back of the book to help with differential diagnosis? And I can tell you that there is not. The American Psychiatric Association, when they published this manual, my understanding is that they really published it for people already familiar with diagnosing. So the idea was that decision trees were not to be made. If you follow the manual and the structure of the manual as it is written, the decision tree is not necessary. However, I can tell you that if you look through the book and go through section 2 and you look up a specific disorder, so for example, if you want to look up substance use disorder with regards to cocaine use, after the diagnostic criteria is listed in the DSM, it will also give you in paragraph form some differential diagnoses to consider. So once again, this manual was really designed for people to actually go into the book and read it, as you'll see as I go further. I have this slide up here just as a visual stimuli to show that the way that the structure of the manual is actually set up developmentally. There is no longer a chapter titled Disorders Related to Infancy and Childhood. Now the DSM has structured the chapter order based on diagnoses that are most likely to occur early on in chronological age, and then therefore the end of the book also follows suit. So the actual first chapter is the neurodevelopment disorders, which are inclusive of things like the autistic spectrum disorder, which a lot of people have lots of questions about. And then towards the end of the manual, it ends with the neurocognitive disorders to have diagnoses of things such as Alzheimer's. Age-related factors are also another variable that has been, I think, considered pretty heavily in a lot of the diagnostic criteria. They've added the criteria for age-related disorders and changed the criteria based on age. So I have an example here that there's actually new criteria to diagnose attention deficit hyperactivity disorder in adults. There's different criteria to be met for things like separation anxiety, which now can also be diagnosed in adulthood. Another example is PTSD. There's different criteria that can be applied for children under the age of 6. So age-related factors are really seen throughout the manual. These next two slides are just a list of chapter order going left to right, and this is the actual order in the DSM as it's published, starting, like I said previously, with neurodevelopmental disorders. Following that is schizophrenia spectrum and other psychotic disorders. That is the new title. And what should jump off the page here is that there's next bipolar and related disorders and depressive disorders are now two separate chapters. Anxiety disorders, and one of the things that is a big part of the changes in this manual is that the anxiety disorders chapter, as it was previously listed in the DSM-4, really has gotten chopped up a bit. Anxiety disorders such as panic disorder, agoraphobia, generalized anxiety disorder, social phobia are included in the anxiety disorders chapter, but there is now a new chapter called obsessive compulsive and related disorders. Also in that chapter includes a new diagnosis such as hoarding disorder. So for those of you that were wondering whether or not that was going to make it into the DSM-5, it in fact did. The next chapter is a new chapter, trauma and stressor-related disorders. I was pleased, as someone who has studied the DSM for quite a few years, that the American Psychiatric Association finally made trauma and stressor-related disorders different from anxiety. And for those of you who treat trauma and stress, I'm sure you'll have the same appreciation for it as I have. One of the things I want to mention here is that along with PTSD and acute stress disorder, the title of this chapter, Trauma and Stressor-Related Disorders, it also includes adjustment disorders. So adjustment disorders no longer have its own unique chapter and is now included in this one. Dissociative disorders remains the same. Somatic symptom and related disorders, feeding and eating, elimination disorders, sleep-wake, sexual dysfunction, gender dysphoria has its own chapter, really separating it from the idea that it is a sexual dysfunction. The next chapter, disruptive impulse control and conduct disorders. The main thing that I can tell you about this chapter is that gambling disorder is no longer considered an impulse control disorder. It has been included in substance-related and addictive disorders, which we'll get into hopefully quite extensively later on today. Neurocognitive, personality, paraphilic, and then, of course, we always have the section of other. One of the things that is also different is there is a separate chapter on medication-induced disorders and medication-induced movement disorders, really recognizing the advances that have occurred in pharmacology and the medications and medical treatments that are used that have caused pretty severe side effects for people to live with. And then we also have other conditions that may be a focus of clinical attention, which most of you are familiar with as the D codes. So I like talking about this slide, and there's a little heart here jumping up and down, as you can see. Many of you, if you've ever had to do a chart audit or look at files, we're always looking at what is the gap. What is the gap at intake? What is the gap at discharge? What does the gap score mean in terms of assigning people to which level of care? And this was never really very useful to anybody except probably for insurance companies. To pick a number between 0 and 100 is not really a good science. So one of the things that was immediately done, as far as the research that I've done on the publication of this manual, is they got rid of it. And I personally am very happy about it because I think it's a better measure. It's not that we're not going to diagnose overall assessment of functioning. We're just going to diagnose it really for what it's intended to be. And so what they have replaced the idea of a gap score with is now called severity specifier. Now, they didn't make it easy in the sense of putting severity specifier in its own chart on a separate page for you to apply to each disorder. What they did is they made it easy by putting severity specifiers at the end of each diagnosis. So, for example, instead of taking just a global number and applying it to someone who has schizophrenia and taking that same number and applying it to someone with an anxiety disorder, there's now severity specifiers for people with schizophrenia, for people with anxiety, for people with bipolar, and so on. So it's really more specifically designed for the diagnostic criteria. And it's not necessarily the same, which I'll mention as we go further. So the severity specifier, just to remind everybody, is really only going to be applied if someone meets the diagnostic criteria. In other words, we can't say that someone has a severe problem if they only have one symptom. They have to also meet diagnostic criteria in order for severity to be assessed. One of the things that this is going to affect, I think, logistically, is that clinicians who are doing an initial diagnostic inventory will need to take more time in diagnosing. And I know, having worked in the field a long time, telling clinicians that they need to take more time to do intakes is often a challenge. I can't stress that enough, though. You're not going to get the diagnosis right unless you take your time. So this is something for those people who are in managerial positions, for those of you who work in facilities and are in charge of your paperwork, intake model, questions that are asked in an initial interview, treatment planning that follows. The dsm5 has a very different construct that needs to be applied, and the general advice is that needs to be probably reworked according to the patient population that you serve. What I have here is just an example. So for those of you who are not familiar with this, think of the severity index as ranges. According to the GAF, anything that was above a 71 was really considered to have no impairment. Treatment was really only going to be paid for by insurance companies and really even warranted for people who suffered with impairment of their symptoms that scored below 70. So here, think of mild, moderate, severe as 1, 2, or 3. This is not to say that this is something that exists separately. In the DSM-4, as you know, GAF scores were listed on one page. These mild, moderate, severe, and in some cases extreme impairment are listed at the end of each disorder as it applies to the diagnosis of each disorder. So just as a global assessment, for lack of a better word, the specifier must indicate at least a level of mild impairment before a diagnosis is validated as a mental disorder. So I think I mentioned this earlier. For a patient with major depression, they must meet criteria of having 5 symptoms first before the severity specifier is applied. And according to a disorder like major depression, just to give you an example, a severity index would include, once the person met criteria of having the 5 symptoms first, then it is the clinician's responsibility to make the judgment of whether or not the impairment is mild, moderate, severe, and extreme for depressive disorders. Other specifiers that I think are a pretty big change for this manual is that now there are specifiers that can be applied to several different disorders as clinically appropriate. My understanding is that there's been an enormous amount of evidence indicating things like bipolar disorder. People who have a diagnosis of bipolar disorder also suffer from panic attacks, but maybe may have not met full criteria of panic disorder, and how do you diagnose that? So they looked at specifiers and said, why not, call it as we see it. We have patients coming in with these symptoms, and unless we make it part of the diagnostic criteria, it's not going to be identified in treatment. So now we have the ability to make the diagnosis and then figure out whether or not a specifier applies. So, for example, you can make a diagnosis now of a depressive disorder and include whether or not there is an anxious stress component to it. There's other different specifiers that are applied. If you look at this list, it's pretty broad. You can have a specifier of catatonia, the seasonal pattern. One of the things that's new is with good or fair insight. I can tell you that that's not a specifier that can be applied to substance use disorders, but it is a specifier that can be applied to things like hoarding. And absent of insight with delusional beliefs, so on and so forth. So once again, it's not that we have to memorize these things or figure out that all of these things can be applied. If you look in the manual, under each disorder, it will list which specifiers can or cannot be applied. So it's really about going into the actual manual and looking at it. So I realize I'm talking a little bit fast. I'd like to just pause for a minute. If anybody has any questions, I encourage you to send them in to the chat. If I can answer anybody's questions so far before I go any further.
Okay, we have one question here. How is anxiety being classified with the trauma or PTSD classifications?
Anxiety is actually inclusive within the diagnostic criteria. So further on today, when I get to the section of PTSD, one of the requirements for PTSD is that someone will have to have a symptom that affects negative cognition and mood, which can be interpreted as an anxiety symptom itself. However, you also can make a diagnosis of PTSD and have separate with an anxious specifier. And I can tell you that with the anxious specifier is very specific. So if I can just pause for a minute and ask you to just hang on a little bit longer until we get to that section. I believe I do have a slide that shows the anxious specifier specifically, because I do understand that this is something that is often seen.
Okay, the next question here is, this person says, I love these specifiers. It's going to be so helpful for diagnostic purposes, but how does one assess for the specifiers, though?
Okay. If you look, again, in the DSM, let's say you're making a diagnosis with someone for a disorder, and just to use the same example, let's talk about depression. Depression, you can use an anxious specifier, and you can also use dissociative specifiers. So in other words, and I think you can also use catatonia as a specifier. I'm not sure. I'd have to look myself. But knowing that you can use dissociation and anxiety as a specifier for major depression, one of the things that is listed is underneath the diagnostic criteria. Once you've determined major depression is the diagnosis, you then want to rule out whether or not there is an appropriate specifier to include. And it doesn't leave much room for guesswork. It actually lists it out. Does the person have a minimum of 2 of the 5 or a minimum of 1 of the following that is also contributing to impairment? The specifiers, in my opinion, also increase the severity index. So, for example, someone who may have major depressive disorder with moderate impairment, with anxious distress, that has the potential to maybe increase the severity index from moderate to severe. just simply indicating that the person is suffering with more than just the depressive symptoms itself.
Okay, thank you for that. I think that's the questions for now. Maybe we can move on.
Okay. Okay, another big change is the not otherwise specified diagnosis. We are no longer going to use things called NOS. I had a graduate professor once tell me that this was the garbage pail diagnosis. And I believe what he meant by this, I hope everybody gets my sense of humor. What I believe, I'd like to think he meant by this, was that you didn't know what you were doing if you diagnosed not otherwise specified. However, NOS was always intended to be used in acute settings only. So for those of you who are familiar with people who come through the door intoxicated, needing detox, or floridly psychotic and hallucinating, it's sometimes impossible to make an accurate diagnosis. So in those specific situations, particularly emergency situations, it's always been absolutely appropriate to diagnose NOS. However, for a patient to be seen long-term, outpatient, have a long clinical record, for the diagnosis to continue as NOS is typically how it was often widely misused. So what they did was they said, okay, NOS is specific, but not specific enough. So to help us not let our patients just wander off with they have something, we're just not sure what, they broke it down. So NOS is now being replaced by two options: other specified disorder or unspecified disorder. So just hear me out. This is kind of a long slide, but other allows the clinician to communicate the specific reason that the presentation does not meet the criteria. However, we know that there is something significant going on. So I have here as the example, if a patient has a significant number of depressive symptoms, but the symptoms fall short of the diagnostic threshold, such as 2 weeks, for major depressive episodes, the clinician would then diagnose other specified depressive disorder, depressive episode with insufficient symptoms. And then obviously there's a code for that. So the idea here, my interpretation of other specified, is the diagnostic symptoms are there. The person meets criteria, but maybe the onset or duration of symptoms is somewhat different. For the unspecified disorder, unspecified is being used now when symptoms are causing clinically significant impairment, but do not necessarily meet the full criteria. So for this example, think of it as someone who may have 3 or 4 depressive symptoms versus the required 5, but has a severity impairment. So when we use this disorder specifier, or I should say when we use this specific disorder, there is impairment in functioning, but the number of symptoms do not meet the full diagnostic criteria. And I think this is important, specifically when you're looking at something like major depression. You can have someone who's highly suicidal, but maybe not saying yes or confirming other depressive symptoms. Would we say that that patient was not impaired? Of course not. But then how do you really verify the diagnosis? So this is a specifier that is pretty inclusive. But keep in mind, it does have to be used in the same way that NOS was intended, which is we don't have enough information, or given the nature of the clinical intervention, there's something that may or may not have revealed itself yet. So instead of just NOS, we don't know, we just know it's depression, they kind of force you to take another step, saying is it other or is it un, which I think is going to be very helpful for a lot of people. Okay, really briefly, I just want to highlight here the first chapter in the dsm5. This is the neurodevelopmental disorders chapter. And if you look here, these are the disorders that are included. So this is the very first chapter. And again, the logic here was these are the types of disorders that would often reveal itself early on, developmentally. So here we have intellectual development, language, communication, autism spectrum, ADHD, learning impairment, and motor disorders. Now, for those of you who treat adolescents and children, there is an enormous amount of changing and an explanation that goes along with the autistic spectrum disorder. And I have to say that it's a very specific training because it is involved, and it's not something that I'm going to be covering here. I can tell you really briefly that things such as pervasive developmental disorder and Asperger's are now included within the autistic spectrum. And I can also tell you that diagnosing autism is no longer as it used to be because they've made these inclusions. One of the things I do think is worth highlighting is attention deficit hyperactivity disorder, as many people with substance use histories and difficulties really do suffer with attention and hyperactivity issues. Sometimes it's a question of whether or not it's related to intoxication or withdrawal issues, and other times it's something that was long-standing that may or may have not co-occurred when the person first started to use the substance. So I do think that this is worth going over. The criteria for attention deficit in the dsm-5 are similar. In other words, there's still 18 possible symptoms. If you're familiar with diagnosing attention deficit disorder, the symptoms itself has not changed. It's divided into inattention type, hyperactivity, impulsivity types, and then you also can have the combined type. But what they changed are a couple of things. You now have to have at least 6 symptoms in one domain that are required. So if you want to diagnose somebody with inattention, there has to be at least 6 symptoms of inattention, and so on and so forth. Other changes, examples have actually been written in the text itself to aid with criteria. I know for myself, as someone who does a lot of this type of diagnosing, oftentimes I would be seeing a student and the language was more geared for a child, or working with an adult, and some of the examples were geared for childhood issues. Now the examples are really more inclusive of age-related difficulties. So, for example, not just having problems at school, but having problems at school and or work, for example. The requirement has been strengthened to have several symptoms in each setting. And the onset criteria, I think this is the biggest change, is that now we can diagnose this very easily with the same exact way that we used to before, prior to age 12. So they increased this by quite a bit. It was usually diagnosed prior to the age of 7. So they gave it pretty much up to children in the 6th grade. Subtypes have been replaced with presentation specifiers. In other words, is the child meeting diagnostic criteria, but really presenting with a hyperactivity type. Now you can co-diagnose attention deficit hyperactivity disorder with autism. That was not something that was allowed previously. And the biggest thing that I think really affects those of us who really primarily work with adults is now we can make a diagnosis for adult onset of attention deficit hyperactivity disorder. And the adult onset criteria is really laid out for both inattention and hyperactivity, and it is different. It's placed in the neurodevelopmental disorders chapter to really reflect the brain and developmental correlates with attention deficit itself. So I think this piece about the adult onset is something that is going to be useful to many of us. So, some questions?
Yes, we have a question here. Is Asperger's not a valid symptom anymore? That means it is an autism disorder?
Not sure what you mean by not valid. I can tell you here's the gist of it. My understanding is that there's been a lot of people, particularly parents, who have a child who's been diagnosed with Asperger's, and their fear is that they're now going to be called autistic, number one, or their fear is that they're now maybe not going to receive the same services that were previously offered. There's two things. everybody has to follow this manual. Everything is listed in the DSM-5, is also going to be listed in the ICD-10. Let's say a service agency who provides services based on certain criteria for those children who met criteria for autism versus Asperger's, they are now also going to have to be inclusive of these changes. So that's the first thing. The second thing is that it's not that the Asperger's is no longer exists. The fact is that Asperger's really had a lot to do with more social impact, and the autism spectrum really had more to do with repetitive behaviors as well. So now, under the autistic spectrum disorder, we now have that option of how we diagnose it. So in other words, if someone truly still has Asperger's, the diagnosis will be able to be made under the autistic spectrum disorder category. I hope that's helpful.
If something is not clear, you guys can continue to send me chat messages, and I will hold on to those questions to be followed up later. The next question we have here is, do you recommend the full version of the DSM-5 to aid us in our practice, or will the desk reference give us enough information?
How did I know that was going to happen? I didn't expect that question to be asked so quickly. I think you're getting, my message here is that this is really about looking into the manual because there's a lot of explanation in there. For myself, I'm someone who uses the desk reference, the pocket, lighter version, which is available. That version is really just going to give you the criteria. It's not really going to give you much in terms of explanation. So my recommendation is that if you are very familiar with the DSM-4, very familiar with differential diagnosing, really have a very solid understanding and experience with differential diagnosing, the pocket reference is absolutely fine. For those people who are not as familiar with diagnostic criteria, particularly beyond things that are familiar. So, for example, for those people that are really used to primarily diagnosing substance use disorders, but not as familiar with diagnosing the other mental health disorders, absolutely you need to purchase the manual.
And now we will transition to the focal point of this recorded webinar: substance-related and addictive disorders within the DSM-5. We are back with Dr. Danielle Moreggi.
I wanted to stop before I got into this section because this is really, I think, the most relevant to this group, my understanding. And also there's quite a bit of change here. So if I can ask everybody to just kind of allow me to go through this a little bit, put your questions off to the side, and so I can field them appropriately. If I can ask everyone to just do that for this section. Substance-related and addictive disorders. Everything in this chapter is listed based on the drug, starting off with alcohol and ending with, of course, other, but tobacco. So unlike the DSM-4, one of the things that was identified early on in that chapter was whether or not someone met criteria for abuse or dependency. And then that criteria, as you know, was then applied to each drug class. I'm going to ask everybody to unlearn what you have learned. That is not something that is going to be practiced anymore. If you think of substance use, what you have to do in order to really understand this new diagnostic system is really to understand and picture that patient or client in front of you and think of their drug of choice. Think of the drug of choice that is the most problematic, that is really the issue of really causing impairment. And for those of you that are immediately saying, well, it's not one drug, it's several drugs, I can tell you that polydependency is no longer an option either. So the idea here is to hone in on the specific symptoms based on the effect of the drug. So that's the first thing, kind of like an overall thing. I think I mentioned previously, gambling disorder is now included in this chapter, It has its own separate criteria and therefore its own separate severity index criteria that is different for the substance abuse. So I want to mention that. So the different disorders, substance-related disorders, are now in two groups. Everything is now going to be called substance use disorder. So there is no longer substance abuse, alcohol, substance dependent, cocaine, no longer. Everything is now substance use disorder, and everything is going to be based on a severity index, which I really would like people's opinion, on this also, because I get a lot of feedback about this, and most people think positively of it once you really understand it. The other piece that has not changed, that has always been inclusive, is whether or not someone has a substance-induced disorder. So you're still going to be able to make the diagnosis of alcohol intoxication, alcohol withdrawal, and other types of induced disorders, such as substance-induced psychosis, substance-induced sleep disorder, and so on and so forth. So those things have not changed. What is the big change is the abuse versus dependency factor, and the fact that we're now calling everything use. Substance use disorder, there has to be, as you know, a pathological pattern that is related to the use of a specific substance. So the idea here is that people will abuse substances. Not everybody would meet criteria for abuse or certainly dependency just based on an incident, for example, that was not typically viewed as a pattern. So the idea is that we're diagnosing people that have already shown this pattern. The other piece that I want to remind you is that the criteria of the past 12 months is still in place. So that is something that is still included. What they did was they took the abuse criteria and the dependency criteria. And if you go back and you look at that in the DSM-4 and really look at it, there's a lot of those symptoms that kind of overlapped. Abuse was always seen as the more mild issue, dependency really seen as the more severe, and then dependency really required tolerance and withdrawal as a diagnostic criteria. That is not the case. What they did is they took all of those symptoms of abuse and dependency and combined it so that it made sense based on the different substances. And what they did is instead of just taking those 21 symptoms and throwing them together, they broke it down into 4 different groups. So this is to, for example, I always think of documentation. As a clinical supervisor over the years, documentation always is a really big challenge for a lot of us, because you can have a good understanding of what the patient is going through, but not necessarily be as clear in how we document it. So if I can use that as an example, one of the things you might want to think about is how you're going to document how you're diagnosing this. And one of the things that I highly recommend is that however your paperwork looks, how we diagnose substance, frequency, amount, stage of first use, things like that, is to now include what symptoms would classify impaired control, social impairment, classify as risky use, or maybe there's pharmacological criteria that's being met. So another question, if I can just cut it off right now, that I hear a lot when I do this training is, does the patient have to meet criteria for each group? No, that is not the case. Some people, abuse substances for a variety of reasons, and some people really are the more risky user versus social impairment and so on and so forth. So there's no specific criteria to be met 1 through 4. Severity is really going to be met based on the number of symptoms. So the first thing is the criteria is now distinguished by 11 possible symptoms overall. So we're looking at substance use, and there's 11 possible symptoms that are highlighted for each specific substance, divided into 4 domains. So impaired control is always going to be indicated as the criteria set 1 through 4. So in other words, when you look at alcohol use disorder and you look at the criteria set for that, the first 4 symptoms that are listed would target impaired control, and then so on and so forth as you go through it. And what I've done here is I've used that as a model. So for this first part, if you take a moment and kind of read through this a little bit, you'll see that the language of abuse and dependency has been intertwined here, that the individual takes substances in larger amounts over a longer period than was intended, expresses persistent desire to cut down, but unable to regulate their use, spends a great deal of time obtaining the substance. Usually these are questions in terms of clinical interviewing that revolve around like daily activities or each drinking or use event. Number 4 is specifically different. It's under the impaired control symptom, and it specifically targets individuals who experience cravings. So number 4, it actually says the individual experiences cravings manifested by an intense desire or urge for the drug that may occur at any time, more likely when in an environment where the drug is previously a former use. Craving, and this is right out of the DSM. This is not my language. In the DSM, under this criteria, it actually gives you an example of how to ask about this question. And this out of the dsm5, it says, has there ever been a time when the person has had such strong urges to take the drug that they could not think of anything else? That would really qualify the person as having craving issues. So that these 4 are under the idea of impaired control. Social impairment is 5, 6, and 7. If you take a look at this, still should look very familiar. Recurrent use, failure to fulfill major role obligations, continued use despite having recurrent social and interpersonal problems, and certainly important social, occupational, recreational activities are given up or reduced because of the use. The third group targets the risky use symptoms. This would be for the person who has been identified as recurring use in situations which are hazardous, continued use despite knowledge of having a persistent or recurrent physical or psychological problem. The key issue in evaluating this criteria is not the existence of the problem, but rather is the individual failing to abstain from using the substance despite the difficulty that it's causing. That is under the risky use. And then in the last group, we have the pharmacological criteria. So this is something that can be applied to each substance. So it is no longer a requirement in order for who we think of as the dependent client. This is the section where we would diagnose tolerance and or withdrawal. So that's the way everything is broken down. There's 11 symptoms, and it's broken down into those 4 groups just to kind of keep the diagnostic questions focused. Now, the big issue is, okay, can't diagnose abuse, can't diagnose dependency, can't diagnose polyuse, polydependency. So here is where I want to kind of address those concerns. The severity index for all substances are going to be based on what you see here on this slide. Mild use is going to be that the person has met 2 or 3 symptoms out of those 11. Moderate, 4 to 5, severe, 6 or more. Now, for those of you who are now going to say, well, what about withdrawal? What about tolerance? If you actually look at the diagnostic criteria, in order for someone to meet criteria for tolerance, more likely than not, they're going to have several other symptoms in order to meet that criteria. And that's the logic here that's been applied. It is not permissible to diagnose mild substance use with withdrawal for any drug class, and they make that very, very clear. The specifiers have not changed. So early remission, full or partial, sustained remission, full or partial, maintenance therapy, controlled environment, and the rules around how to diagnose that have remained completely the same. So early remission being 30 days, sustained being a year, maintenance therapy being things like methadone, Suboxone, controlled environment being residential and Department of Corrections, things like that, all have remained the same. So the next issue is, okay, how do I record this? How do I document this? The idea is this. If you haven't figured it out, and you will see this in other disorders that have changed in terms of the language, everything is really based on how specific can we be, because the idea is that the more specific, the more accurate the diagnosis, the more accurate the documentation, and therefore the more accurate the communication from one treatment provider to the other, which is really where a lot of people can drop the ball to make of our own. So the idea is that if we really can be the most specific we can be in getting the diagnosis right, then treatment and treatment planning and outcomes will then follow suit. So just to give you an example, the clinician would record 304.10, which is the current DSM language. And as you see here in parentheses, there's a new code, T13.20. That is what you're going to see in terms of ICD language, which is coming. Does not need to be applied yet, but that's the new lingo. And for those of you who have questions about it, that is actually listed in the dsm5. So it does have both the DSM-4 codes and the new and upcoming ICD codes as well. So getting back to how we diagnose this, clinician would diagnose moderate alprazolam use disorder rather than moderate sedative hypnotic use disorder. So here you would communicate very specifically mild, moderate, severe, and you would communicate very specifically the drug of choice. Alprazolam, as many of you know, is Xanax, and can have a very different symptom profile than things like Valium, even though it's in the same drug class. So that's how specific the DSM-5 is asking you to be. When someone does meet criteria for more than one substance use disorder, all will need to be diagnosed separately. So there's no more polydependency. What you would do is for that poly user, severe heroin use disorder, moderate cocaine use disorder, mild cannabis use disorder, just to give you an example of how each one would be diagnosed. Now, I think this is a good thing because I think that diagnosing accurately drives treatment. And one of the things I know is often challenging for many of us is dealing with reimbursement, getting, sessions approved for people. And my, the glass is half full attitude with this change is that if we make a diagnosis that really gets this specific, then treatment planning can now follow this. Recommendations, different protocols, recommendations for level of care and reasoning as to why and why not someone would meet that diagnostic criteria. When we would diagnose polydependency, it was kind of just global in nature and not really addressing the specific issues. And for those of us who work with people with, poly use, we know that, someone who's abusing heroin has a very different symptom presentation than someone who's smoking marijuana. And so to have treatment be driven by the diagnosis itself actually can be helpful in our treatment planning and then hopefully having more successful outcomes. Okay. Let me pause here because for the next couple of slides, okay. Withdrawal symptoms have not been documented for hallucinogenics, PCP, and inhalants, so that's not part of the symptom criteria. So when you go into the DSM-5, withdrawal is not an option as a symptom to be checked off because it doesn't happen. And that's the benefit of, now having each criteria under the substance itself versus applying abuse dependency to each substance. Criteria set for withdrawal are provided for each drug class, and neither tolerance or withdrawal is required for a substance use disorder. So I think we probably have quite a few questions here. Okay.
Okay, so the first question here is, one of the first two criteria for impairment, the number one talked about the need to use more? How is this different from tolerance under pharmacological criteria?
Okay. I'm kind of going back and forth here myself. Requiring a marketing entries, market effects disorders. This is, I think, what I meant by tolerance. If someone met the criteria for tolerance, it would be inclusive of having met the criteria for number one. So the individual takes substances in larger amounts over a longer period of time than was intended, and then getting to the root of it, which is requiring in order to increase the desired effect. It's really a language thing. There's a slight difference. But the idea here is that you can have somebody who chooses to use more than was intended, but requiring more in order to gain the intoxication effect is specifically different and based on physiology and pharmacology. But clearly if somebody met criteria for number 10, they probably would be inclusive of meeting criteria for number 1, and then therefore the person would qualify as having a diagnosis. Because then if you go back and you look at mild, moderate, severe, you have to have a minimum of 2 symptoms. So if someone was really meeting criteria for tolerance, it would be inclusive of number 1 and then therefore meeting diagnostic criteria. Hope that was helpful.
How can I be certain I'm documenting properly using the new criteria for substance use disorders? How can I practice this documentation and get my work evaluated?
Okay, practice in terms of practicing, like, getting better at it from practice, or practice in terms of professional practice and applying it. Is kind of what I'm a little bit confused about, and how you can get some feedback, or I believe the question was evaluated by it. Was that part of the question, Petra?
She means yes, both.
Okay. Well, the suggestion I have here is I would go specifically into the substance use chapter in the DSM-5 and read it, first of all. By reading it and going through alcohol, cocaine, cannabis, and so on and so forth, you'll see that the 1 through 11 criteria is the same, and then the mild, moderate, severe criteria is the same. The only difference with the severity index in this chapter is with the gambling disorder. So all of those things are the same. So it's really about identifying the drug of choice, and if there's more than one drug of choice, then going through mild, moderate, severe measures for each drug of choice. And as far as in practice, I think that really comes from how we document it. So depending on what your documentation currently looks like, for example, does Phoenix House have a standard documentation that's used across all settings, or does it vary from program? Okay, so it varies. Depending on the type of patient or clients that you're treating, this may or may not already be applicable. I can tell you that the way that I would do it, and the way I would do it is I would go through, okay, you're using alcohol. Okay, how much alcohol are you using, so on and so forth, and I would literally go through each one of these things, kind of getting verification. What are the symptoms? Is this about impaired control, risky use, so on and so forth? And then at the end of that, assigning the severity index, because that's really what's going to dictate level of care and dictate treatment planning. My concern is that we do not know how insurance companies are going to handle this, and Medicaid and Medicare are going to handle this. So I would imagine that if this is the required usage for us as professionals, they also have to follow suit with their requirements as well. So they're also going to be, I'm sure, informing us of many changes to come. So that's about all I can say about that right now.
Okay, our next question here is from Donald Rader, military case manager, and he asks, you spoke previously about the Axis 5 gas being taken out. Is this the case with the axis 1 through 4 as well, or is this a myth?
Oh, very, very good question. There is no more 5-axis diagnosing. 5-axis diagnosing was intended basically to say, okay, axis 1 being the clinical disorder and the disorder that was identified as needing intervention, and then 2, 3, 4, and 5 was to substantiate that axis 1 disorder. That was the original logic and how 1 through 5 was applied. We now no longer do 1 through 5. So, for example, the HCFA form, the insurance form that we all use, axis 1, 2, 3, 4, 5, treatment updates, outcome reports, outpatient treatment update reports, all of those things that we're all familiar with using, we have to wait and see how insurance companies are going to handle it. Now, next question usually comes after this is, oh my God, personality disorders are now a real reimbursement disorder. I will get to that a little bit more specifically later on in the presentation, but I can tell you right now, yes, personality disorders, there's no other axis to put them on. So it has to be the clinical axis. However, as you would imagine, the severity index is very different. So the person would have to be severely impaired with something like borderline personality disorder and things like that. So that is something that is still going to be up to the governing bodies if what they consider reimbursable, treatable, and so on and so forth.
Wonderful. Thank you so much for that question. I think that's all the questions for now.
Okay. All right. Those are very, very good questions and helpful to me as well as I go through this. Okay. The next chapter is anxiety disorders. I believe I mentioned earlier when we were going through the brief chapter order that anxiety disorder chapter no longer includes obsessive compulsive disorder. Obsessive compulsive disorder is now included in its own chapter of obsessive compulsive and related disorders chapter. That's a chapter I'm not going to go through here. We just clearly just don't have enough time to deal with every chapter. But I do want to highlight that is a separate chapter, and that is a chapter that includes a very new diagnosis of hoarding, which a lot of people have had questions about. The other omission from the anxiety disorder chapter is PTSD and acute stress disorder. PTSD now has its rightful place in its own chapter. One of the things that I think is extremely relevant as far as the anxiety chapter, there's no change in panic disorder on how we think of panic disorder. There's no change in how we think of how a panic attack gets diagnosed or generalized anxiety. All of those things remain the same. Generalized anxiety still requires 6 months and so on and so forth. All of that is the same. What has changed is that panic attacks can now be listed as a specifier that is applicable to all dsm5 disorders. So this is the notion of many people who report having had a panic attack, but maybe never have another one. Or maybe they're not worried about having another panic attack. And I want to remind people, it may have been a while since you've actually looked at the DSM and looked at how to diagnose a panic attack. We all know, panic symptoms when we hear them described by a patient. But what the DSM required was panic attack was never considered a disorder itself. Panic attack was always classified within the diagnosis of panic disorder. And the requirement for panic disorder required that the person had a panic attack and the panic was about re-experiencing another one. So that really excluded a lot of people. What about the people who've had panic attacks, just don't want panic attacks, have them randomly, they're not necessarily worried about having another one that would cause impairment. No one wants to have one, but that's not necessarily something that was impairing their functioning. So this is why this was included, because there is, a physiological phenomenon to panic that has to do with neurotransmitters that has really been involved with really the majority of the research that's been done by a lot of pharmaceutical companies. Just to highlight, for example, antidepressant medications, are used as frontline treatments, not just for depression, but for all the anxiety disorders. And that's really due to more physiological brain chemistry, which varies from individual to individual. So that's a big change in the anxiety disorder chapter. The other big change is now agoraphobia has been revisited. In earlier versions of the DSM-5 prior to 4, agoraphobia was considered its own disorder. And then they took it out, and they made it in the DSM-4 only applicable as a specifier to panic disorder. Well, that's not working very well. So they went back and said, okay, people with agoraphobia in it and of itself has its own symptom profile. So now you can diagnose panic disorder and agoraphobia as separate disorders. I think this will enhance making recommendations for level of care and treatment severity, the fact that you would kind of dually diagnose someone and really see the person as panic disorder as having one level of a symptom profile and also inclusive of agoraphobia that has another symptom profile. That's something that would certainly enhance severity and warrant more treatment. The descriptors for agoraphobia are unchanged. Endorsement of fears from 2 or more situations are required. So the person would have to be fearful of open spaces and fearful of being alone without companionship in terms of not just publicly, but maybe even specifically to neighborhood, communities, familiar places, work, school, recreation. So it would have to be across settings, not just in a specific place. Specific place, when it comes to panic, usually leads to things like social phobia or a specific phobia. So the inclusion of the agoraphobia piece has really kind of made it more specified. Social phobia, there's a lingo change here. Social anxiety disorder is now the proper term, something I myself have to get used to. I'm very used to saying things like phobic and phobia. That's no longer the case. So the proper terminology is now called social anxiety disorder. And the generalized specifier is replaced with performance-only specifier. So this is for those people who would meet criteria for having extreme anxiety and an impairment in functioning in specific social situations, and it also includes a performance-only specifier. In other words, it's not just a person experiencing anxiety within a social context, but it's when the person is required to do something, to speak or to communicate or interact socially. And the other piece is selective mutism is now included as an anxiety disorder. That was something that was in a different category, and it's now included in the anxiety disorder section. Another change that I think is significant, I don't know how often you would necessarily see this, depending on the patient population, but I thought it was worth mentioning. Separation anxiety used to be considered a childhood-only disorder, and now there's been evidence that separation anxiety can occur in adulthood. And so it's no longer listed just as a childhood, or I should say even thought of as a childhood disorder. Now criteria can specify that the age of onset is either before or after adulthood. And for adult onset, the criteria must last for a minimum of 6 months or more. And I also want to make specific that this, along with everything else that you always see in the DSM, not due to the effect of a substance, not due to bereavement, not due to trauma, things like that. So those caveats would still be there. Okay. Any questions? Just be fidgeting around over there. Okay.
Okay, one question coming up to us from clinician Ron Nevelo. Does that mean that OSD is when the diagnosis doesn't meet the time requirement, and USD when you are short the number of necessary symptoms? This goes back a little.
Is that something I can kind of answer towards the end to kind of just open it up just generally? I wanted to make this part specific to the section that I was covering. I do want to answer that question without a doubt.
Okay, so Ron will get to that question later, but for now we can move on. I think this is all the questions.
Okay. Okay, this is something I have mentioned so far a few times. It's about trauma. And this is a new category. It's inclusive of the disorders where exposure to a traumatic event or stressful event is listed explicitly as the diagnostic criteria. And it would take several hours to go through a whole lesson in how to diagnose PTSD and acute stress disorder. The assumption as far as this presentation is that this is just a review of the training, or I should say of the changes. Although I love to talk about trauma, I'm going to try to keep this as brief as I can and relevant. The disorders in this section include reactive attachment disorder. That was something that was in the childhood section, put in trauma and stress-related. Disinhibited social engagement disorder, also often referred to as a childhood disorder, is now here. PTSD, there's criteria that is separate for children under the age of 6, which, ironically, I do need to mention this, being from Connecticut, everyone is aware of the Sandy Hook tragedy, and we're coming up on that anniversary here in Connecticut next week. And the DSM went into publication on December 1st. So the DSM had already, the task force had already decided that there was a different trauma symptom profile for children under the age of 6. And then Sandy Hook happened 2 weeks later, before the manual was actually published. And I think that's pretty significant, that that's certainly a population that is going to be re-diagnosed now when we're dealing with children. And it's really based on evidence and research. Acute stress disorders, and then the big change is that we no longer have a separate chapter for adjustment. Adjustment is considered to be a stress-related disorder. The essential feature of PTSD, just to kind of go over this briefly, there's some sort of emotional reaction. The response does not have to be intense fear or horror. The idea is that the person has to experience a tragic event, but it is not necessarily required that the person would describe as horror in general. So that's a big textual change. Another thing that's changed is that you can have a specifier whether or not the person has dissociative symptoms with regards to PTSD. The way that I have been taught in my training, and I have trained other students, is that dissociative symptom profile was always more indicative of acute stress. When people first experience a trauma, they're more likely to dissociate, be in shock. I don't know how this happened. Did it really happen? It's surreal. And that was really always associated with acute trauma. And dissociation was not necessarily really recognized in PTSD. Well, now you can have a dissociative specifier for PTSD. And clearly in my experience in working with, adult survivors of, previous traumas, there's more often than not always a dissociative factor that's there. And usually, for those people that do experience those types of symptoms, can be, a big focus of treatment is when they can go back and experience dissociative symptoms. So there's a separate specifier that is inclusive of kind of like a dissociative syndrome that goes along with PTSD. It's not just applied to acute stress. The PTSD criteria itself, the exposure is defined in several ways. So if you look in the DSM itself, it's pages to diagnose PTSD. Exposure is defined as experiencing a traumatic event directly, hearing about something suddenly, either through the media that was not intended, being indirect relationship to the trauma. So there's different ways of how we define exposure to a traumatic event. The next criteria is that the person has to have a minimum of one intrusive symptom. So an intrusive symptom would be something like a flashback. Minimum of an avoidance of stimuli symptom. This would be, avoiding people, places, and things, associated with the trauma. Then the next criteria set is to have a minimum of 2 negative cognitions and mood. And here's where you would have issues of negative thinking, a lot of people who go through traumatic events have very global negative thinking, where they think, life is not worth living. They have more of a depressive disposition because of that negativity, and that's within the PTSD profile. Then we have a minimum of 2 arousal and reactivity symptoms. These are symptoms such as hyperarousal, where people feel kind of jumpy and kind of looking over their shoulder, a very easy or unnatural startle effect due to a trauma. And then the same time and duration is that the symptoms are more than 1 month. There is a separate criteria for under the age of 6 that is also listed after this in the manual itself. A big change is the acute stress disorder. The essential feature is the development of the characteristic symptoms of acute stress and lasts from 3 days to 1 month following the exposure. Prior to this, acute stress disorder was more than 1 day. So now, based on the research, and I can tell you specifically, they looked at a lot of the research that has come from the 9/11 tragedy that we suffered. A lot of the research has come from that basically says, there are tragedies that we are now exposed to in the world that we weren't necessarily exposed to before, and a lot of that has to do with the Internet. So I'd like to just remind everybody of the horrific things that have now been posted on the Internet of war and violence, things that are accessible to the public. Ironically, today, the state of Connecticut will be releasing the 911 tapes from the Sandy Hook tragedy for the public. These are things that were not necessarily brought into people's living rooms or in the palm of their hand on their iPhones. So the idea is that the world has gotten worse, and we've gotten more exposed to how bad the world is. And so, having a very abnormal reaction to an abnormal event is normal. So once it lasts more than 3 days, now it gets to be more symptomatic of a disease profile, or I should say a disorder profile. Symptoms that resolve immediately after a traumatic event within 3 days would not meet criteria. So it's really, I would say, more than 3 days is really the language that is best used, but I don't know why they didn't make that more specific. The acute stress criteria defined exposure in the same way that PTSD is. And here, instead of having PTSD where it was 1 of this, 2 of these, 1 of those, kind of like a cookbook method, this is the presence of 9 or more symptoms from any of these 5 categories. So you still have intrusive, negative mood, dissociation, avoidance, and arousal symptoms, but you don't have to have 1 of these, 2 of these, and so on and so forth. So the idea is that the person is experiencing quite a bit. Another reason why acute stress disorder it has changed because of what we now have learned about trauma is they made the criteria more substantial, pretty much allowing people to be, I would say, quite symptomatic due to a traumatic event and really consider that as more normal functioning, kind of like a normal reaction to an abnormal event, and kind of giving people that out instead of being slapped with a diagnosis. They made the diagnosis a little bit more difficult to meet criteria. Adjustment disorders are now included in this chapter. The subtypes have not changed, and the criteria in which we diagnose adjustment disorder has not changed at all. The only thing they did was they just moved it into a different section. So adjustment disorder is still adjustment disorder. All right, we're getting into kind of the home stretch here. A couple of more areas to cover, and then I believe we're going to have quite a bit of time for Q&A at the end to kind of go through overall questions. Okay. Brand new chapter, bipolar and related disorders chapter, really signifying that bipolar symptomology is different than just depression. It's also located in the chapter right after schizophrenia spectrum, which I believe puts bipolar disorder chapter as the 3rd chapter in the manual. Really, again, indicative that this is research is showing us that it's more developmental and physiological in nature. The bipolar-related disorders, as far as the disorders itself and how we diagnose mania, hypomania, has not changed. So there's nothing to relearn here in terms of, okay, how do I now diagnose bipolar disorder? Bipolar disorder, it is what it is. It's manic, it's hypomanic, it's depression, whatever that is. So the issue is that it's being put in as a separate chapter. So we still have bipolar 1, bipolar 2. I heard rumors that there was going to be a bipolar 3. That is not the case. Cyclothymic is still there. We can also diagnose substance medication-induced bipolar and related disorders, and bipolar disorders related to another medical condition. And then, of course, we have other and un for bipolar. Now, I want to point out here that the substance-induced bipolar disorder is duly listed. It is in this chapter, and it is also listed under the substance-induced disorders in the substance use disorder chapter as well. So it's not like you're going to miss it. What I have here, and some of you, I believe at least one person had alluded to a question like this earlier. I put here an example of the type of specifier that is really often seen with people with bipolar disorder. One of these specifiers that I've talked about you can have with anxious distress. So under the bipolar disorder, it gives you how do you actually go about diagnosing with anxious distress. So the idea is that anxiety can occur during manic, hypomanic, or depressive episodes. So it can occur under any mood episode. And then the criteria for the anxious distress specifier would be met by having 2 or more of the following. And if you just look at this criteria, anxious distress to me diagnostically looks like generalized anxiety, feeling keyed up or tense, feeling restless, difficulty concentrating, feeling that something awful may happen, feeling that one may lose control. It's a little bit of a mixture of general anxiety and a little bit of a panicky kind of feeling. And clearly, I kind of deal a lot with mood disorders, particularly bipolar 2. And I do see this a lot. So myself included, I have gone back with my patients in my private practice and reassessed, like, what is the diagnosis there? Would it change? Is the diagnosis the way that I have it listed? Is it robust enough and valid enough? So this is something I highly suggest that if you are treating people with bipolar-related disorders, this is definitely something that you want to look into to see if this diagnostic indicator applies. The specifiers for bipolar-related disorders, I put this here because I think bipolar disorder is something that we see a lot with substance use. So the severity specifiers for bipolar disorder slightly different. Mild is a minimum of 2 symptoms, moderate severe, and then severe. So here you can see how the severity index is really being applied to the diagnosis itself, versus just that global assessment of severity or impairment. So here you would have, for example, bipolar 1 is diagnosed by having at least 1 manic episode. Bipolar 2 having at least 1 hypomanic episode, never reaching mania. And then, therefore, the mania and the hypomania would be assessed in this way. Because in order to meet diagnosis for bipolar 1 or bipolar 2, you already have to meet depression as a diagnosis. Because if there was no mania or hypomania, it would be a depressive disorder. So when it comes to, symptom severity, mild, moderate, severe, and then severe, it's really being applied to the different types of manic episodes. Depressive disorders. Okay, there's a bunch of new and pink balls here and things to include. Depressive disorders has expanded, and one of the reasons why they moved bipolar disorder over to the separate chapter in and of itself. What we have here, as I marked as new, is disruptive mood dysregulation disorder. This is a disorder that is specific to children under the age of 18. And this is a disorder that pretty much was put into place because of the issue that has occurred over the last 2 decades, really, of diagnosing bipolar disorder in children. This is a very, very specific disorder. It requires a lot of different categorical minimum qualifications in order to meet this disorder, and it cannot be diagnosed once the patient is above the age of 18. So in other words, once the person has reached 18, they have to be reevaluated for another type of mood disorder. That is something that if you're working with children and adolescents, you definitely want to look into this. Major depressive disorder is the same. Dysthymia is exactly the same, but it has a new name, and it is called persistent depressive disorder. I can't tell you how many times myself I cannot get used to this persistent depressive disorder language. I'm very used to thinking of dysthymia in a particular way, but the idea is that, again, the disorders are being more specific and descriptive. A lot of people don't understand what dysthymia is. So to change it and say it's the people who have persistent depression makes it more specific. A new disorder, premenstrual dysphoric disorder, has made its way into the DSM under the depressive disorder chapter. Now, I can tell you that this is not a female who suffers with premenstrual symptoms. If you actually look in the DSM, when I read this, when the DSM came out in late May, and I read through the criteria, I said to myself, oh my, if anybody was experiencing this level of dysfunction, I would hope that they would call it a disorder. It's really that severe. So it's very, very specific in nature, has a lot of minimum of this, not due to this kind of diagnostic criteria. But it's in there, it's new, and it's valid, and based on research according to the APA. Then we have substance medication-induced. Again, this is also duly listed in the substance use chapter. And then we have depressive disorder due to a medical condition, and then other and The severity index for depressive disorders is different than bipolar disorders. Here we have the severity indicator. Mild means that the person meets number of criteria. So, in other words, if the person has persistent depressive disorder, otherwise known as dysthymia, it means that the person has met criteria for that disorder and met it in terms of duration, 2 years, and symptoms, and so on. That would be mild. Moderate, indicating that they meet the number of criteria, and intensity is between mild and severe. For a manual that tried to be very, very specific, this doesn't sound too specific to me. This is pretty much really obviously up to clinical judgment, but that is the language right in the DSM. And then severe, number of symptoms exceeds what is required, and intensity of symptoms is seriously destroying impairment and is unmanageable for the patient. So these are the severity specifiers for the depressive disorder. And then if you look in this chapter, there's pages listed where depressive disorders, these are all the specifiers that can be applied to any of the depressive disorders. You can have a specifier of anxiety, mixed features, melancholic, atypical, mood congruent psychotic features, mood incongruent psychotic features. That brings the question of how we would diagnose schizoaffective disorder, for example, whether the mood or the psychotic symptoms were congruent or not with the psychosis, with catatonia, with peripartum onset, meaning before childbirth, versus postpartum. The postpartum is its own separate. And then with seasonal patterns. Big change with depressive disorders is really this bereavement exclusion. There are some people that are a little bit confused by this. I hope I can clarify it as simply as possible. What's confusing is a little bit is because it's called a double negative. Bereavement exclusion is omitted. It's kind of saying the negative is no longer negative. One of the things that was in the DSM-4 was when you would diagnose, let's say, major depression, one of the criteria was not due to the results of bereavement. And then therefore, if somebody came in and met full criteria for major depression, was suicidal, severe impairment, couldn't function, couldn't sleep, couldn't eat, we said, oh, you're not majorly depressed, it's due to grief and loss. Well, we now know from research, based on a lot of different types of research, the fact that pharmacological interventions are helpful to people who are going through grief and loss, and also the fact that bereavement is a real pathology that really impairs functioning, where you would have somebody who may not have already met criteria for major depression, but now really meet criteria for major depression, regardless of whether or not it's due to grief and loss. So I actually think that this is a good thing. I know for myself, I would see patients in my private practice that would come in very, very severely depressed, no history of a mood issue or any other reason, but very severely depressed. What diagnosis do we give them if there was this bereavement exclusion? Now we don't have to do that. Now we can say that it's depression and it's due to bereavement and therefore treatable. So that's the basic difference. Really, there are different ways to kind of look at bereavement versus major depression, and that's usually in how people talk. For example, one of the things that people will say when they feel suicidal due to major depression is that they don't want to be here anymore. Whereas when people are suicidal due to bereavement, they say, I don't want to be here anymore without the person of loss, or I want to be with the person, somewhere else in heaven. So it's usually in the description of how people talk about it, which again would come to how we went about clinical interviewing. This next piece, and I believe this is the last piece, or second to last piece we're going to do, this is the schizophrenia spectrum and other psychotic disorders. This chapter is one of the first chapters. It's right after the neurodevelopmental chapter, and it includes all the different psychotic disorders as we already know them. Delusional disorder, brief psychosis, schizophreniform, schizophrenia, schizoaffective, and so on. Nothing here has changed except other and un. What really has changed, brief psychotic disorder is still diagnosed based on time and duration. So in other words, brief psychotic disorder is still applicable for people experiencing a symptom of psychosis under 30 days. And schizophreniform is that duration of over 30 days, less than 6 months, and then meeting criteria for schizophrenia requiring 6 months. Okay, all of that is the same. However, once we get to schizophrenia, the big change is that there is no more subtypes applied to schizophrenia. So no longer are we going to diagnose schizophrenia paranoid type, schizophrenia disorganized type. What they found in the research is that the disease tends to vary, especially across the lifespan. So, indicating one subtype versus another actually can sometimes interfere and negatively impact treatment outcomes. So now we're just looking at schizophrenia as a psychotic experience, not necessarily related to a subtype. One of the things I do want to point your attention to is that there is, in Section 3 of the manual, clinician-rated dimensions of psychosis to help you with how to rate symptom severity. And the idea is that the task force for the DSM really felt like, okay, we're spending a lot of time on the severity index, and, psychosis is severe. Having hallucinations and delusions and that level of impairment in functioning already is very severe. And this is something that was often misdiagnosed, especially when it came to GAP score. So in order to help people who are maybe not so familiar with how to diagnose severity in a psychotic patient, there's now this clinician-related dimension that is located in Section 3 to be helpful, so that it can help clinicians rate impairment in functioning, and it's based on a Likert scale, a 5-point domain. Now, don't get nervous. There's no change to personality disorders. I just wanted to put this in. This is something that probably got the most press with regards to really came out as like a big controversy, so much so that they said, oh, wait a minute, sorry, we made a mistake. And then they went back and they included 6 of the 10. Well, they decided, and this was decided right at the very end, right prior to the December 1st deadline of last year, before the manual went into publication. The task force basically decided, or I should say the board of directors basically decided, look, there's an enormous amount of changes in this manual, and if we change personality disorders along this new dimensional model that has been proposed, quite frankly, I think they were afraid people were not going to use the manual. I know that myself. When I looked at it, I was like, wow, you have to be kidding me. And, I do this and train this for a living. It was that much of a massive overhaul. So what I can tell you is that there's absolutely no change. The difference is that there's no more a separate axis. Okay, so what does that mean? It'll be listed as a clinical disorder, but symptom severity will determine the level of impairment for treatment. So my guess is that symptom severity will be something of a level of impairment that would require a level of care, level 3. That's my guess. It would have to be at least a level 2 in order to be co-occurring with something else, but clearly a level 3. But that remains to be seen. There is an alternative, what they call hybrid model. That is the original proposal of the task force. They did slide it in to Section 3, and it's a guide to future research. And for those of you that are familiar with previous manuals, there was always this, kind of back of the book consideration, disorders of, future consideration. So my guess is that it may not be in the DSM-5 right now, but it's probably coming. So it's just a bigger thing that once we finally get used to looking at the DSM-5, my guess is that, this new hybrid model for personality disorders is coming. So based on all this, now what? One of the things I just want to highlight, just based on this really brief training that I've gone through today, is to remind everybody there is no more 5-axis system. All the disorders are now listed in Section 2, including personality disorders and intellectual disabilities. This was a comment that was made previously. Intellectual disabilities is the new language for mental retardation. So we're still making that diagnosis. The new proper language is called intellectual disability, and it is still based on mild, moderate, severe levels. The way that it's diagnosed is slightly different. In other words, it's not just based on IQ score alone, it's based on social impairment as well. So that's some slight changes, but that's really more indicative of the childhood disorders. So there's no more 5-axis system. I think I've made it pretty clear the replacement of the NOS. The other specified, allowing the clinician to communicate the specific reason that the presentation does not meet the criteria. And then the unspecified, when the symptoms cause clinically significant distress but do not meet the full criteria. Implementation of the severity index, the rating scale, this is going to vary across time, circumstances, and disorder. This is where really having that manual, whether you have the desk reference or you have the full manual, you're going to need to look at the manual. What I briefly just mentioned previously about bipolar disorder, bipolar disorder having that, moderate, severe, and then severe category, and then depression having just mild, moderate, severe, versus the substance abuse that we went over, having a minimum of 2 and more than 4. The severity indicators will be listed in the desk reference. So you don't need the full manual in order to have that there because it's part of the diagnostic process. But it's going to be different, or I should say it is different. The rubric is listed below each criteria set. So in other words, when you look at bipolar disorder, the rubric of severity is applied right there, what you need to do. Age specifiers, some of the big age specifiers are listed here. Again, obviously because of age, it has more to do with the childhood disorders. PTSD in children, this disruptive mood dysregulation disorder. This you might see, clearly in adolescent treatment settings where the patient or client would be diagnosed with like bipolar-related childhood disorder. There was never such a thing as childhood bipolar disorder. And if you look at bipolar criteria, mania and hypomania, it was very difficult to apply that to child and adolescent behavior. So this disruptive mood dysregulation disorder really targets things that are more age-related and then doesn't necessarily follow the patient for a lifetime. They have to be re-diagnosed or reassessed, I should say, at the age of 18. Then we have attention deficit hyperactivity. Children now can be diagnosed up to the age of 12. There's a separate adult criteria for over the age of 17. And then another big age difference is how separation anxiety is now have an adult onset. I would pay very close attention to this when you're looking at borderline personality disorder. One of the main criteria about borderline personality disorder is fear of abandonment. And reckless attempts to avoid abandonment, real or imagined. That can very much look like separation anxiety. So that's a differential diagnosis you might want to pay attention to. No more abuse or dependency. We are now calling everything substance use with the severity specifier. And then one thing I was not able to get to that I do want to call your attention to is the cultural considerations that are included in Appendix 3. The DSM has done, I think, a really, really good job of really including the idea of culture and diversity, more so than ever before, whether it's gender-related, community-related, language-related, and so on and so forth. So there's this different ways that we can look at what are the cultural influences in terms of diagnosis. And these are some resources that are available in Appendix 3, and also there's resources available online. What can we expect? We can start using the new codes now, but we're not required to do so. So if you pick up a copy of the dsm-5, you can start to use the new codes, but we're not required to do so. In October of next year, the U.S. will adopt the ICD-10, and that is the model that we all will be using. Insurance companies will likely be sending out a rollout plan this coming January. For those of you who are practicing clinicians and in charge of billing, you know that CPT code was a big change this past year. And there was a rollout. You know, I started to get mailings in the next 3 months, we're going to be doing this. In the next 3 months, you have to fill out this form. And then they gave you, you know, kind of a cheat sheet, you know, the coding system, how they were going to change their rates, so on and so forth. I suspect that insurance companies will be doing the same thing with regards to how the HCFA form may change. I do not know exactly what those changes will be. I don't think anybody does. And then you definitely can expect a change in your paperwork and documentation. Things that will definitely be more specific, not necessarily longer, just more specific. I think that there's going to be more focus on the upfront evaluation and assessment of the disorder than ever before. And so in terms of time and, you know, logistics of how we're going to practice, you know, clearly the diagnostic assessment is more specific and requires to give more time to it. So I'd like to end today and open up for questions. But before I do that, after just going through this brief overview, which I realize is a lot of information, how do you feel in terms of needing more training? If you feel like you need more training in the DSM-5, are there specific areas that you think more of? You know, do you need more specific training in substance use, more specific training in trauma-related disorders? And how many hours of attention do you think you really have to give these changes to this new manual? And that kind of speaks to that practice effect question that I tried to answer earlier. You're going to need to consult, definitely. There is no expert in this manual. I hate to say that, but I've been training the DSM since I think 1998, and I certainly was considered an expert in the DSM-4, but the DSM-5 just came out in late May. There is no expert. You know, we're all getting used to this manual. Certainly knowing the DSM-4 criteria helps, but my advice is just to remember the DSM is not the be-all, end-all. It's a tool. And it's the clinician and clinical judgment and experience and clinical supervision that I really think is the most important thing. We have to talk to each other. We have to say and admit, I don't know how to do this, and ask for help. Because when we get the diagnosis right, the patient benefits. That's the bottom line. I always have a phrase, and people are familiar with the phrase, it is what it is. It's a phrase I use all the time, but it's also, it isn't what it isn't. If the person is not meeting criteria, they don't have the disorder. So it's, this new manual is really forcing us to be more focused. My advice, the book is new, be proactive in seeking out information from a variety of sources. So with that, I want to leave you with a page of references here and resources where I've gathered my information. I want to guide your attention to psych.org and dsm5.org. Here you will have an enormous amount of materials made available to you. I can tell you bare minimum, okay? Instead of asking for a copy of this PowerPoint presentation, go to that website and download the highlights of the DSM-5. It is, I think, a 20-something page document that really highlights all of the changes, and it will be very, very helpful. And that will also be a pretty good measure of how comfortable you'll feel and whether or not you do more training, because it's just the highlights. So if you're following what's changed and what hasn't, great. If you're saying, wait a minute, not sure how much I understand this, that is a good measurement or assessment of probably needing a little bit more training in this new manual. Okay, that's right.
Wonderful. Thank you so much, Dr. Muraji. We have some questions here. The first one, I'm going to go back to Ron Nevelo's question from Texas, where he asked, does that mean that OSD is when the diagnosis doesn't meet the time requirement, and USD when you are short the number of necessary symptoms?
Yes, I would like to thank you for waiting for me to answer this question, first of all. But if I can go back to previous slide, and the unspecified is really when there is insufficient information. There's not enough information, but clearly there is an impairment. So this is where you would make the diagnosis. Clearly the person is impaired and in need of treatment, but we don't have enough information at this time, or the symptoms that we can at least assess or verify are not enough to meet the full criteria. Whereas the other is, pardon me, this is when the person is not quite fitting the diagnosis. So in other words, the patient has a number of symptoms, and we know it's depression, but they don't quite fit the onset and presentation of how a major depressive episode would occur, or how mania would occur. I can't tell you how many times I worked in an ER, and I saw somebody clearly manic, clearly bipolar, in a manic episode, but the mania had only lasted 3 days. Now, am I going to wait a full week for this person to be in a full-blown manic episode before I'm going to diagnose them? Absolutely not. So that's kind of the best example. I do want you to kind of think of it in this way. And something I do want to mention that I myself want to go back to is that this other and unspecified is not applicable to substance use disorders. Okay? When it comes to substances of use, it is or it isn't. So this is not, do they meet criteria? Do they not meet criteria? Is it other? Is it un? It's there or it's not there, and then it's mild, moderate, severe based on that. So I did want to mention that, make that clarification.
Great. Thank you so much for that. Okay, the next question here comes from Richard Becker from Phoenix House, Augusta, Maine. And he asks, can you review the difference in PTSD and acute stress disorder?
Okay, review as in teach it, or review as in what I said? Hang on, let me try to get to this. Okay, PTSD and acute stress. The main thing that I would think of PTSD as is that both PTSD and acute stress is defined by having an exposure to an event. And that exposure to the event could be directly, indirectly, through the media, things like that. That's the criteria for both. And for PTSD, other than the duration of it needing to be, more than 30 days, there is very specific symptoms that have to be met. There has to be a minimum of 1 intrusion symptom, 1 avoidance, 2 negative, 2 arousal in the criteria. If that person was over 30 days, let's say you see somebody with like delayed onset, okay? Years ago they were sexually abused as a child, clearly they have PTSD, but maybe they have intrusive symptoms, avoidance symptoms, 1 mood, 1 arousal. What diagnosis would that be? It would be unspecified because the actual symptoms would not be met. So that's kind of the difference. The acute stress, there is an increase in the days, and it's 9 or more symptoms of 5 categories. Whereas with PTSD, you have to have 1, 1, 2, 2, 1. Here, it's just a minimum of 9 from any of these categories, and it's done in less than 30 days.
Another question, again by Richard, was, will the ICD replace the DSM-5?
I don't know what's going to replace what. I can tell you that the DSM is not the rule. The DSM is the tool to help those of us who are clinicians in the art of clinical interviewing and diagnosing. The ICD-10 is the manual with the code that is listed. And I point that to the rigorous structure that you have to go through to get through medical school. Doctors use the ICD. They're medical doctors and board certified and so on and so forth. And those are the ones that have access to it. With the DSM, the mental health professionals that have access to the DSM are not necessarily psychiatrists and psychologists. And so because of that, the DSM will always be a tool because technically only psychiatrists and clinical psychologists are trained to use the manual. And so I do think the DSM 5.1 or 5.2 is probably going to come out and continue.
Thank you. Okay. So next we have Yesenia, I'm sorry if I'm pronouncing your name incorrectly, Cologne, who's an adolescent counselor in New York, and she asks, so does this mean there are only axis 1, 3, and 4?
Okay. Everybody needs to forget about the 5-axis model. The person needs to be considered as having a clinical disorder or more than 1 clinical disorder or not. The axis model itself is completely gone. And I want to say this because in earlier manuals of the DSM, certainly in the first and second manual, there was no axis system in place. We just diagnosed people and we based our treatment recommendations based on the diagnosis. Now, we are also used to using V codes. In other words, family distress and so on and so forth. It's not considered diagnostic criteria if someone is having social issues. The idea is that the diagnostic criteria has now become so specific that if there is a medical condition, if there is a social condition or an environmental condition, it is included in the criteria set. So for example, like with attention deficit disorder, like I had mentioned earlier, right in the diagnostic criteria, it gives you examples of disturbances at home, disturbances with primary caregivers, so on and so forth. So it's not that we're not paying attention to axis 3 and axis 4, but we're looking at it as, what criteria actually meets the disorder of clinical attention. We, instead of having V codes are still listed, not reimbursable, but still listed. The ICD has Z codes. So, the whole language of this whole thing is really changing, and it's hard. It's really hard to embrace when you've been taught a five-axis system. Oh, wait, how do I think about diagnosing?
Wonderful. Okay. The next question comes to us from Samantha Peller, National Clinical Trainer, Phoenix House Foundation, and she asks, what about complicated grief or complicated bereavement? Is this considered a diagnosis label, or is this addressed in the DSM-5? What section of the DSM-5 would this be otherwise addressed, if not in the section under trauma?
Ooh, okay. Bereavement is not under trauma. Bereavement is in the depressive section, and let me see here. What was the question? I'm sorry, it's kind of a long question.
Not a problem. What about complicated grief or complicated bereavement? Is this considered a diagnosis/label?
Complicated grief and bereavement, no. The idea is that if the person is experiencing anxiety, if the person is experiencing mood, or even experiencing, psychosis, and it is due to bereavement, there is no more bereavement exclusion. In other words, we're not excluding the real diagnosis of major depression or the real diagnosis of panic disorder just because the person is grieving. We're going to give them the diagnosis of panic disorder if they meet that criteria, or major depression if they meet that criteria. As far as V codes, that is not something that was ever really a legitimate documentation issue, as much as it was just a communication from one clinician to another. So I would say, yes, you can continue to do that because the ICD has Z codes, and I think they're pretty much the same thing. But as far as diagnosis, it's never really a diagnosis. That's my understanding. So.
Great, thank you. Okay, next question is from Bob O'Donnell, military case manager from Brentwood, New York. Where are we going to express Axis 3 medical issues?
Where are we going to express Axis 3 medical issues? I don't know, quite frankly. I mean, that's my answer. I do not know. I do not know where we are going to be required to insert this. I do know that the way that I have always practiced, as many of you have, is that medical conditions have always been listed separately, right? If someone came in and let's say they had a thyroid condition or, were recently diagnosed with cancer, can we clearly say that that may be influencing the person's Axis 1 condition? Absolutely. But it's not required as part of the diagnostic picture. So, again, this is that framework of it's not that we're not talking about medical conditions. It's that it's a separate issue, and it's either there or it's not. In your description, if you want to say, okay, ever since the person has been diagnosed with cancer, the person has been depressed or anxious, that's where you might want to look at, is this an adjustment disorder? Is this a stress-related condition? It's kind of forcing you to really know how to diagnose versus kind of say, okay, click, 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 they have this symptom, click, they have Axis 3, click, they have Axis 4. This manual really was not designed to help us bill, or code. The manual is really saying, look, you got to know how to diagnose. And if you don't know how to diagnose, this manual is here to help you. So it's really about kind of going in and reading it. So it's not that we're forgetting about it. It's just it no longer really has to be part of the reasoning for treatment, if that makes sense.
Great, thank you for that. So we're just going to move on here to Carrie Terrell, Assistant Manager in our Texas region, and she asks, is rule out a diagnosis still an option for clients who we assess and make the initial diagnosis for insurance authorization prior to our psychiatric evaluation?
My understanding is in no way was rule out ever really supposed to be applied for insurance reimbursement. I kind of want to defer back to this was something that we do as a communicative exercise to communicate either from provider to payer or provider to provider. So rule out, there was never a code for rule out. You know what I mean? Yes, we could put the code in for the disorder we were ruling out, but rule out as a code didn't exist. So that's one part of it. The other part is now we have other and un. So here is where you could actually put a code for those disorders that you are considering to rule out. So for example, let's say you're diagnosing someone with major depression, and there's a question as to whether or not they may or may have not had a manic episode in the past. You don't know if this is a bipolar-related depression. One of the things that you can do is if there's evidence that that may or may not exist, the bipolar part, you would diagnose the major depression and then put unspecified bipolar-related disorder, as just a kind of like a working diagnosis, because that's really, it may or may not actually fit the full criteria, depending on the presentation. So that would be my suggestion, and it's probably a more robust, way of approaching documentation as well.
Thank you. Okay. The next question is from Peter Priolo from Phoenix House, Brentwood in Long Island, New York. And he asks, this is going to be a long question,
Okay.
Considering the change of disorders over time, acuity, reflected in the new diagnosis, would insurance companies be seeking for substance abuse diagnosis to show improvement over time in the treatment episodes, such as maybe beginning with a severe level at admission but ending treatment with a mild level? Or are addiction diagnosis not acute?
I think that is a fantastic question. I really do, because that's, coming from, someone who's kind of managing a program where you're going through a very specific program where you have an admission, what we otherwise refer to as GAF, and then a discharge GAF. One of the things that we want to look at is the person getting better? I do not know what insurance companies are going to do. Okay, I do not know. I believe that their task force are, gathering, their troops to figure out how they're going to manage this. But what makes clinical sense to me is that, yes, severity index would change. However, that also cannot be necessarily exclusive of the remission indicators. So the way that I really think this is going to happen is that I believe that when a patient comes in and they're authorized for treatment and their disorder is severe, it stays at severe. That's what we're treating them for. And then remission indicators are probably going to be the more important piece. And if insurance companies do that, I think that that's very good for us as treaters of these patients, because when and if a patient relapses, for example, do we reassess at that point? Or do we kind of, still consider it as partial remission and so on and so forth? It kind of goes back to, really looking at symptom presentation and what we really are treating. I do think that there's going to be rating scales that may be asked of us. So let's say Anthem Blue Cross Blue Shield may not necessarily base their session allotment based on severity index, because we no longer have a gap, but they may ask us to use rating scales for each symptom, which in some paperwork that's already really been the case, as I've heard from other clinicians. So that's something that, insurance companies can do what they want, within reason, but they can design their requirements, based on, outcomes and improvements. So the diagnostic code, mild, moderate, severe, not necessarily something that may change.
Great, thank you. Okay, so Kristen from Girls Recovery Lodge in Arlington, Virginia asks, bipolar disorders, does it appear that some of the changes, particularly the agitation specifier, will make it easier, more challenging to differentiate diagnosis from ADHD? Also, what about ADHD from ages 12 to 17? In your review, it appears that is no longer a diagnostic option in that age range.
If I can address this backwards, because I kind of lost the first part of the question. Okay. It's not that there's no diagnosis from age 12 to 17 for attention deficit disorder. The idea is that the symptoms have an onset prior to age 12 and have an onset for adult symptoms that are different than the prior to age 12 subset. So, for example, prior to the age of 12, we know that a child, has X, Y, or Z symptoms, okay? If we assess this child or adolescent at the age of 15, we're still assessing for the presence of attention deficit disorder prior to the age of 12. So, is there an assessment that can be made for attention deficit disorder? Is there evidence there? It was still the same consideration when we tried to figure out whether attention deficit disorder was there prior to the age of 7 when we were assessing 15-year-olds. But now it comes the question of, okay, well, maybe this is a symptom that's just occurred, in the past year, in the age of maybe 14 to 15, and there's no ADHD diagnosis there. Guess what we would do? Other on would be the applicable diagnosis there. So it would be unspecified or other specified for that range that was not specific. And then as far as over the age of 17, it's that adult criteria that is then therefore applied. The earlier part of your question, let me see here. Some of the changes, particularly agitation specifier, will make it easier or more challenging to differentiate diagnosis from attention deficit disorder. No, I do think that since your question seemed to be very much related to adolescent behavior, that this disruptive mood dysregulation disorder really covers a lot of that agitation specifier, attention, impulsivity issue. You can duly diagnose this disruptive mood dysregulation disorder with attention deficit disorder. But if you look at that disruptive mood disorder, it really does kind of carry over and really, I think, very helpful with that, what we usually refer to as childhood-related bipolar disorder. So I kind of want to defer you to that, or at least defer you to another training that specifically looks at that.
Thank you. Okay, and the last three questions here are coming from our counselor from Phoenix House, New York. And the first question is, how do we diagnose clients whose substances are greatly connected to trauma? Are these separate or considered two co-occurring diagnosis codes?
Really good question. I would say that a lot of it would depend on the duration of the substance use. So if you're dealing with somebody who's using a substance and it's causing impairment, you want to make sure that you're also using that first rule of thumb in the last 12 months. It would be pretty indicative as to whether or not it was very specific in your investigation of symptoms. Did the person never use a substance, but ever since they, went through, a car accident, now they're abusing a substance, or ever since, they went through some sort of stress, now they're abusing a substance. I want to remind everybody that, a lot of symptoms are not due to the effect of a substance, not due to the effect of a medical condition. All of these things are in, kind of like your differential bag here that you have to filter. So would it be considered a separate diagnosis? Here it is. It is what it is, and it isn't what it isn't. When you're looking at diagnosing, if the person is meeting criteria, boom, 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 and they meet criteria for PTSD, and the person is meeting criteria for that substance use disorder, mild, moderate, severe, it's duly diagnosed. It's not necessarily that one cancels the other out. And in those situations where, there is this blurred line, how does this new manual really apply to this? This is where we have to go back and really, start to look at clinical supervision, consultation, and things like that, because it really, really varies, and depends on the individual. So I hope that was helpful.
Thank you for that. Okay, so the next question is, you briefly mentioned substance-induced disorders. Can you remind us what specifically changed there from the DSM-4 to the new DSM-5?
What specifically changed in substance use?
What specifically changed there from, you briefly mentioned substance-induced disorders.
Oh, okay.
Can you remind us what specifically changed there from the DSM-4 to the new DSM-5?
Nothing. Substance-induced disorders, you can still have induced disorders such as like induced mood, induced psychosis, and we still have substance-specific intoxication, substance-specific withdrawal. We still have, alcohol intoxication as a diagnosis just as much as we have substance-induced mood disorder, alcohol.
Wonderful. And our final question here, in the substance-related substance use disorders, is there any terminology or guidance on the phrase with psychotic features? I remember having clients with that specifier in the DSM-4 because they did not qualify for a psychotic disorder diagnosis, but may have temporarily presented with these features.
I'm not sure how to answer that question. I think you're talking about maybe someone who, to me, when it comes to substances and psychotic features, it depends on intoxication, withdrawal, and the substance. So first I would want to know, what substance are you talking about, and is there a legit brain chemistry that would cause that? So for example, we know that certain stimulants such as, cocaine and amphetamines can cause psychosis. But, long-term standing psychotic experiences for, LSD, not the case. There's different conditions for alcohol, and all of those things are based on intoxication versus withdrawal and what is the substance. I understand what you're saying, that, there is a psychotic piece, that can be, the longer-term side effects after substance use. So it's not due to intoxication, it's not due to withdrawal. Is this a psychotic disorder? Again, I want to bring everybody back to, not thinking about things as a rule out, not thinking about things in that way, but really thinking about things in, do they meet criteria? Do they not meet criteria? If they're not quite fitting the criteria, it might be an other. If there's insufficient symptoms, it's un. And then somewhere in the middle, you may have, depending on the substance, for example, I'm looking at the DSM right now, and I want to look at stimulant intoxication. And when you're looking at stimulant intoxication, it says to you, not do specify whether there are perceptual disturbances. So if you're looking at stimulant intoxication, you can specify whether or not the person is having hallucinations, but has an intact reality testing. So, this is about really going into the manual and really looking at it, and seeing what you can and cannot do. If you can't apply it, it's not listed. If you can apply it, it's listed there as an option. It's not like we have to memorize it. You just got to go in there and look.
Okay, and one last question has come in from Patty Schneeman from the Mid-Atlantic region, and she's asking, what category of drugs would you put OTC, bath salts, spice, other designer drugs?
I believe that it is in the other category. Hallucinogenics, it depends. If you're looking at, PCP, that's a hallucinogenic, versus, ecstasy, is that a hallucinogenic, is it not? My understanding is that, ecstasy was always considered, a hallucinogenic. But I believe that has moved over to the other category, just to be more specific, because obviously it's a very different drug than something like LSD or PCP. I want to remind everyone that when we are making a diagnosis, We are now putting it as the specific substance of use. So if you're unsure as to what diagnostic category the substance is, let's say bath salts, okay, you do not have to put the category. What you have to put is moderate bath salt use, severe bath salt use, just like we were doing mild, moderate, severe alprazolam. So you're really putting a specific drug in there versus, okay, what part of the chapter is this a hallucinogenic, is this other, so on and so forth. So that, I think, is more important. Thank you, everybody, for your questions today. I hope today was helpful. Thank you for your attention.